Hi, good morning. Warm welcome. Thank you to Dr. Sudeep Gupta and Tata for this invitation. Today I'm talking about loco-regional breast cancer and the management of axilla for women. So the first publication is sentinel lymph node biopsy versus no axillary surgery in patients with small breast cancer and negative results on ultrasonography of axillary lymph nodes, the SOUND trial. Uh, so the background is the question asked is, can we omit sentinel lymph node biopsy in a small subset of patients with small tumors less than 2 centimeters with a pre-operative ultrasound saying the lymph nodes are negative? It was mandatory that if the lymph nodes looked suspicious, FNA of the lymph nodes was done. From the Z11 trial, we know that there's no advantage in doing an axillary dissection in patients with up to 2 lymph nodes positive. And especially if they're receiving radiation and chemotherapy. So the question is, should we perform SLNB in this subset, and will ultrasonography replace staging for axillary lymph nodes? It was a randomized control trial with a non-inferiority trial. Patients enrolled had tumors up to 2 centimeters with a median size of 1.1 centimeter. Patients received axillary radiation and chemotherapy. They were randomized into the SLNB group versus no axillary surgery. 1,400 women randomized. Median age 60, tumor size 1.1 centimeter, more than 87% were hormone positive and HER2 negative. And both arms received chemotherapy in about 20% of patients. Both arms radiation therapy in about 98 versus 97.6%. And the results were that there was no difference in the loco-regional relapse, in the distant metastasis, in death, the 5-year disease-free survival, the 5-year overall survival between the two arms. So they say that there's no benefit from axillary lymph node surgery in women with small breast cancer, though the incidence of sentinel lymph node positivity was about 13.7% in the sentinel lymph node group. The incidence of node recurrence was very low at 0.4% at 5 years. The authors conclude that patients with small breast cancers with ultrasound showing normal lymph nodes, sentinel lymph node biopsy may be spared, especially where the information about the nodes may not change the postoperative treatment plan. But we know that this subset is already a very low risk subset. So, and this follow up is only for a period of 5 years. So I think a longer follow up would be required. And are we really ready to leave behind the information which we receive from sentinel lymph node biopsy, especially in younger patients where we know with node positivity, if they receive chemotherapy, there's a survival benefit. People with with a HER2 positive disease, when nodes are negative, we do de-escalate chemotherapy to just receive Pacli and trastuzumab. And for small TNBCs, do we still need the information from the nodes? Also, I think node positivity gives us indication to add CDK4/6 inhibitors, and the duration of endocrine therapy is also determined by the node, whether it's negative or positive. Can we de-escalate hormone therapy? Can we add or remove ovarian suppression depending on node positivity? And many patients, especially I think in the Indian setup, coming from rural places, older women above 65 years of age, where we say we can relieve radiation if we do a mastectomy. So are we talking about de-escalating sentinel lymph node biopsy and with the potential to increase radiation exposure? This study also did not include the grade of the disease involved. We know grade 3 disease, there's a higher incidence of nodal positivity. Also, for women with more than 1 centimeter tumor size, usually genomic studies are advised for hormone positive. Both of these information was not included in this study. So I would say we all know that for older women with hormone positive, HER2 negative, small tumors, we do omit sentinel lymph node biopsy, but I think this still needs a tumor board discussion before we can omit sentinel lymph node biopsy for patients with small tumors, especially younger women and triple negative breast disease and HER2 positive disease. The second article today is lymph node positivity of axillary reverse mapping lymph nodes at the time of axillary lymph node dissection. It was a 2-center prospective trial. So we know that ARM or axillary reverse mapping is done to discriminate and to identify the arm lymph nodes, the afferent lymphatics from the arm. using a radioactive tracer on the breast and blue dye on the arm. Um, Different rates of crossover nodes or lymph node positivity in the sentinel group between the arm and the breast, with studies ranging from 5 to 19% between Caucasians and Asians. What is the oncological safety of leaving the ARM lymph node behind? The incidence of arm lymph node positivity varies dramatically between 18 to 80% between various studies. And what is the role of axillary lymph node dissection in the contemporary era post Z11 trial? Because most patients receiving axillary dissection are people with advanced disease, nodal disease, chemo-resistant disease. What is the metastatic involvement of ARM lymph nodes in patients undergoing axillary dissection? Prospective trial with the endpoint to study lymphedema in patients with axillary lymph node versus axillary lymph node with immediate lymphatic reconstruction. And this is just a secondary point studied. People with prior axillary dissection, prior radiation, preoperative lymphedema, and pregnancy were excluded. Blue dye was injected in the arm and the volar surface to identify the ARM lymph nodes. 139 patients included in the study, and in about 55% of 55 patients, or that is 41%, the ARM lymph nodes were identified and marked. Younger patients with lower pathological node status with prior heavily treated chemotherapy, identification of ARM lymph node was more positive. It was noted that patients, when ARM lymph node was positive, the nodal disease state was higher. The authors conclude that higher incidence of metastatic involvement of ARL lymph node in patients with ALND is up to 20%. And in today's era, with the adoption of Z11 trial, patients requiring ALD are a subset of patients with chemo-resistant disease or high nodal disease, and removal of ARM lymph nodes should remain as the standard of care. Again, ARM lymph nodes were positive in 28% of the patients receiving axillary dissection. Hence, it's not safe to leave behind the ARM lymph node. And also, when ARM lymph node there was a failure to map the ARM lymph nodes, it is suggestive that the nodal disease is much more, and axillary dissection is required. So, as of today, we would say that leaving behind ARM lymph nodes in patients undergoing axillary dissection is not safe and should not be the standard of care. Thank you.